Good morning. My name is Davide Martino. I am a movement disorders neurologist and program director of the movement disorders clinical program at the University of Calgary. And today I am very happy to present you on the issue of non-motor symptoms in patients with dystonia. And particularly focusing on understanding the clinical spectrum, how to detect them, and how and what we know about how best to manage them. This is briefly my outline for the talk. I will start by giving you an overview of the spectrum of non-motor symptoms in cervical dystonia and other adult onset isolated dystonias. I will essentially focus on this most common category of dystonias, which are the adult onset isolated dystonias, which encompass cervical dystonia, blepharospasm, oromandibular dystonia, writer's cramp. Whatever possible, I will refer to individual forms if needed, but I will also, when I mean the full spectrum, henceforth I will refer to it as dystonia in general. So I will focus mostly on pain, depression, anxiety, sleep, and fatigue, as these are the best and the most investigated of non-motor features that are present in these patients. I will then move on to an aspect that I am particularly interested in, which is how to understanding barriers and facilitators for appropriate screening and management of non-motor symptoms in dystonia, and how moving forward towards a new pathway of care might improve our efficiency in doing this. And I'll conclude with just some special considerations on the relationship between pharmacological management and mood symptoms in dystonia. So first of all, we all know that dystonia exerts a substantial negative impact on quality of life. There is a very large now body of evidence showing with great consistency that non-motor symptoms matter to a great extent in influencing quality of life of people with dystonia. So I'm showing you this diagram from a large international study from the Dystonia Coalition Consortium, which is a worldwide consortium, although primarily US-based, that has sealed this concept of impact of non-motor symptoms and quality of life of people with dystonia, using the largest ever patient of cohort of more than 2,000 patients. The degree of depressive symptoms and of generalized and social anxiety in people with dystonia seem to be the factors that impact more than anything else, essentially all the domains that compose quality of life in people with dystonia. But following behind depression and anxiety, increased dystonia severity in terms of severity of motor symptoms was associated only with worse physical functioning, physical role and emotional role functioning, and social functioning. And the presence of tremor in dystonia correlated only with worse physical functioning and pain. Interestingly, in this study, younger age was associated also with reduced emotional well-being and vitality. And no difference between sexes was observed in terms of impact on health-related quality of life. So this clearly seals the concept that depression and different forms of anxiety are important determinants of quality of life, if not the most important determinants of quality of life in dystonia. Similar type of concept applies also to disability, which is a construct that is close to quality of life, but it's not the same thing. Of course, the two are quite correlated. Most of the data that we have on disability in dystonia come from cervical dystonia, and we are all aware that many patients, despite motor improvements with botulinum toxin, many patients with dystonia still may experience trouble in performing some daily activities. And again, studies on disability show that the largest contributors to this construct in people with dystonia are mostly non-motor symptoms, and particularly depression, anxiety, and pain, even more than physical functioning and severity of the motor symptoms of dystonia. The spectrum of non-motor symptoms in dystonia is quite broad, as I mentioned at the beginning, and relatively complex. Apart from the already mentioned ones that I will delve deeper into in the next slides, I also would like to highlight that people with dystonia may at times complain of apathy, which may or may not be related to depression, and this definitely needs to be investigated. We will talk about what catastrophizing might mean in patients with dystonia, but they also may display some sensory disturbances different from pain, even including olfactory and visual problems, for which, however, there is very limited evidence. So I'm going to start by from pain, because pain is probably the most common non-motor symptom in some forms of dystonia, and particularly cervical dystonia. The frequency of pain in cervical dystonia ranges across 55 to 90% approximately of people with this condition, with this form, across different studies. Although it typically localizes in the same areas that are affected by dystonia and cervical dystonia, so shoulders and neck, it may also spread to other areas, the upper back. They may go up to the head, usually on the side that is bent, and may even go down to the ipsilateral upper limb, which might, in certain situations, suggest a need to investigate more the cervical spine. The quality of this pain is reported as in different ways by patients, as exhausting, radiating, neck pulling, prickly. Interestingly, a non-trivial proportion of patients with dystonia, particularly cervical and cranial dystonia, may have chronic daily headache, which may have different distributions across the head regions. We know that people with blepharospasm may feel pain when exposed to bright lights, the so-called painful photophobia. And even patients with focal hand or even lower limb dystonia may report pain, and again, not in a trivial percentage, which is between 35 and 40%. However, we still need to understand better how to best classify pain in dystonia, and we need more dedicated rating tools to assess pain and measure its severity in people with dystonia, which is an area that we are particularly interested in working and completing the work on in Calgary. Obviously, the hypothesized mechanisms of dystonia are also in need of a better ascertainment. There's no doubt that pain in cervical dystonia might come from, but also in other forms of dystonia, might come from muscles, so may be due to the prolonged contraction of dystonic, but also of the muscles that compensate the dystonic posture, which are pretty subcontinuously contracted. There is some evidence, which is a bit scattered, indicating that there may be an alteration of brain processing of painful stimuli in dystonia. For example, a recent study in focal hand dystonia has shown a reduced tolerance of pressure pain in these patients. In people with cervical dystonia, we also know that higher levels of acceptance of living with pain may co-occur with lower levels of perceived pain, which is a pretty obvious and expected finding. What is also interesting, however, probably more interesting, and this is coming from a study that was led by Catherine Peel's team in Cardiff, in Wales, in people with cervical dystonia, a catastrophic interpretation of pain, which leads to a perception of pain as particularly severe, disabling, and incapacitating, correlates with the severity of depression and anxiety, which again is a quite intuitive finding, but also suggests a potential interconnection between pain and depression and anxiety in people with dystonia, but also suggests that different forms of pain may have different mechanisms, at least in the way that pain is interpreted in people with dystonia. there isn't much on how to best treat pain in dystonia. There is no doubt that there is reasonable evidence suggesting that botulinum toxin injections relieve pain, particularly in cervical dystonia, but even in blepharospasm. And sometimes this is an effect that is maybe present even in the absence of a very convincing effect on muscle contraction. So I believe that most of us have experienced the situation in which a patient reports that spasms, movements, and posturing have not improved, particularly after a cycle of botulinum toxin, but they have felt better pain-wise. People with dystonia may often use oral medications to try and relieve pain, and usually this use is non-specific, and they typically prefer using over-the-counter medications that do not need a prescription. It is, however, useful to monitor them in daily life, in daily clinical practice. We know that deep brain stimulation for those patients who require it may, in cervical dystonia, reduce pain. And there are only preliminary results that definitely need verification of some physical measures like the use of the kinesio tape on the shoulder and neck muscles, or even non-invasive neuromodulation of some brain regions like the cerebellum. Moving now to mood symptoms and anxiety. Depression and anxiety are probably the most important of these symptoms. This is an experience from a relatively short number of patients from the Calgary Center, just to indicate that when depression and anxiety are screened with very long and sensitive instruments like diagnostic interviews, like the scheduled for DSM diagnosis, the SCID-1, we can observe the presence of a depressive or anxiety disorder in up to 2/3 of these patients, even, at least with a lifetime diagnosis, and something around 50 to 55% as a current existing anxiety or depressive disorder. This is compared to hemifacial spasm patients, who are seen in the same centers but do not have dystonia, obviously, but are treated in a similar way. In these patients, this psychiatric comorbidity never really exceeds about 30–35%. There does not seem to be any obvious difference in the presentation of dystonia from a motor standpoint between those with and without depression. Particularly, there doesn't seem to be a difference with on spread, on the way that dystonia spreads from one body side to another. But a recent study coming from an Irish group in Dublin has shown that there's a significant difference in age of onset of dystonia between patients who have depression and those who do not have depression, with the depressed ones having reporting an earlier age at dystonia onset. In writer's cramp, even in writer's cramp, not only in cervical or cranial dystonias, we can find an important coexistence of anxiety and depressive symptoms, clinically relevant symptoms or disorders. You can see that the frequencies range between 46% and 51%. And importantly, higher scores of depression severity are associated with lower scores of physical and mental determinants of quality of life, even in people with writer's cramp. So this is not the association between depression, anxiety, and quality of life in people with dystonia. It's definitely not limited or restricted to people with cervical or cranial forms of dystonia. We have conducted a couple of years ago a population-based study using Swedish registries with colleagues from the Karolinska Institute in Stockholm to confirm the association between psychiatric disorders and isolated dystonia. And we confirmed, even in using this more robust methodology that allows to evaluate this association on a population of millions of individuals. We could identify a twofold increased risk of diagnosis of depressive disorder in people with dystonia, and a 2.13-fold increased risk of anxiety disorder, but also an 80% greater risk of suicide attempts or death by suicide compared to the general population. One of the most interesting and striking findings of our study has been also the observation of a similar association even in full siblings of patients with dystonia who do not have dystonia, but still have a greater risk of having during the course of their life a diagnosis of depressive or anxiety disorder, which suggests that there may be a shared heritability between dystonia and some psychiatric disorders, including mood disorders, as has been also partially confirmed by a study that looked at gene expression, which was led by Nicola Mencacci in London, and definitely requires more studying and more investigation. An important point is that about 60% of patients who have depression and dystonia do report an onset of depression that antedates the onset of dystonia, which is, again, suggestive that depression and anxiety are not simply consequences of having dystonia. We have conducted systematic reviews on this topic to better understand the prevalence of depression and anxiety in people with dystonia, also to inform new clinical studies. And the vast majority of the studies that we have reviewed are service-based studies, are not population-based studies. And we found an overall pooled prevalence of about 31% for cervical dystonia, and about 29% for cranial dystonia, and 31% in studies that examine mixed forms of dystonia. This is in respect to any depressive symptoms or disorders. Major depressive disorder confirmed to be the most prevalent overall, although people with cranial dystonia may, in some studies, report higher prevalence of dysthymia compared to major depressive disorder, which is interesting, as it might suggest that some depressive disorders may be associated more with some forms of dystonia than others. Similar findings and a similar type of study we performed for anxiety disorders, showing that across the board of cervical and cranial dystonia, social phobia is the most commonly reported diagnosis, 25%, followed by generalized anxiety disorder, 18%. There is quite a large heterogeneity between studies in terms of prevalence estimates, which indicates that that even across research studies, the way to assess these symptoms is quite different. But important finding from the Dystonia Coalition cohort is that social anxiety reaches the highest prevalence in people with laryngeal dystonia, which is also quite intuitive given the social relevance of speech and voice, even more than head posture or facial movements. This is another important study that comes from Finland. It's a population-based study that indicates how the presence of comorbid depression in dystonia and cervical dystonia is associated with an anticipation of age at retirement. If you compare these two survival curves, the black and the red one, the red indicates cervical dystonia patients who do not have anxiety or depression, and the red are the ones who are also anxious or depressed. And as you can see, that time to retirement is shorter in these patients, which clearly indicates that managing mood symptoms in dystonia may impact on productivity in middle-aged adults. Another question that we asked ourselves is, does this social anxiety or social phobia or social problems that patients with dystonia may report and manifest, is it related to social cognition? So the ability to process socially relevant, socially salient stimuli. And a number of studies have been performed on this topic, very few actually. In our study, we found, this was a study exclusively on cervical dystonia patients, that more than 90% of these patients perform normally on tests tapping on social perception and social behavior, with only 22% showing reduced performance on theory of mind and 11% on empathy. They also show more difficulties with the identification of fearful faces. But one important finding in our study is that greater levels of social phobia or social anxiety were associated with an improvement even in some of these social cognition tests, particularly a test of social perception, which indicates that patients with dystonia have an efficient modulation and self-adaptation of social cognitive skills, which supports the potential for applying cognitive behavioral treatment to treat social anxiety in these patients. And indeed, there is very limited evidence on the application of CBT in patients with dystonia. This is a pilot study that was conducted by, again, the Welsh group, which focused on an internet-based CBT program for individuals with cervical dystonia. 16 patients completed the study and were either randomized to an internet-based CBT platform plus routine clinical care or routine clinical care only. What they found was the study, the treatment lasted 8 weeks. First of all, they found very high engagement of this population of patients, which is unsurprising, but also a greater trend towards depression and anxiety score improvement in those receiving internet-based CBT at 3 months, with this improvement sustained at 6 months, particularly for measures of depression. Although there were differences across different rating instruments. So this is a pilot study. The difference was fell just below the level of statistical significance, but overall, this studies provide some promising preliminary results that at least in a good proportion of these patients, the use of internet-based CBT might be beneficial. Are people with dystonia who also have depression and anxiety more prone to use medications? This is indeed what was found in another cross-sectional dystonia coalition study published a few years ago and led by Sarah Piria-Richardson, in which it clearly appeared that if there was anxiety or depression present, patients were twice as likely to be taking oral medications, which are also useful for dystonia, at least some of them. And in particular, there was a tendency to overuse benzodiazepines and other sleep-inducing medications like zopiclone, but also muscle relaxants and even anticholinergics. And I'll touch on these medications at the end, the last few slides of my presentation. What about antidepressants? Should they be used with people with dystonia? Now, there is really no valid reason to feel extra cautious to treat depression and anxiety when needed with antidepressants like SSRIs. We still don't have a very strong evidence that antidepressants improve depression in patients with dystonia. There's been only one study that has tested escitalopram in cervical dystonia, but it was a small study and it had some patient selection issues, in my opinion. So evidence is really very limited. And in my opinion, this lack of evidence does not justify the lack of treatment if depressive or anxiety symptoms are relevant, clinically impactful. Does botulinum toxin improve depression and anxiety in dystonia? Again, the evidence is very controversial here. I'm just citing this very last study, one of the latest studies looking at this, that showed that when using some tools, some rating instruments like the Hamilton scales for anxiety and depression, that people with cervical dystonia receiving botulinum toxin type A improved not only in motor symptoms and in pain, but also in depression. However, using other instruments like the psychiatric section of the twisters for cervical dystonia, this change wasn't found. Overall, this study does not really answer definitively this question. Maybe variability across patients. But what was interesting is that there doesn't seem to be any clear correlation between the degree of change on motor symptoms and that of non-motor symptoms like pain and depression or anxiety, which indicates that if botulinum toxin has an effect on non-motor symptoms, it probably goes through mechanisms that are different from those that help motor symptoms in dystonia. Deep brain stimulation surgery generally does not significantly change anxiety, mood, or cognition in people with dystonia. There have been some improvement in patients presenting at baseline stable but moderate or severe depression. But this safety should not bring our guard down with respect to be cautious of appropriately screening and monitoring for neuropsychiatric problems in patients who undergo DBS. Let's move now to sleep issues. And again, do people with dystonia have sleep problems? Well, yes, they do. And there is, again, some heterogeneity across prevalence estimates in different studies. But some earlier investigations have shown how at least half of patients with cervical or dystonia or blepharospasm may have a poor quality of their night sleep, with increased latency to fall asleep, decreased efficiency of sleep with increased nocturnal awakenings, and less refreshing sleep or REM sleep. There is no doubt that there's essentially the severity of dystonia is not correlated with the severity or the presence of sleep problems in people with dystonia. Poor sleep quality seems to be more influenced by concurrent depression, which again comes up as one of the most important and impactful symptoms in people with dystonia. The presence of sleep difficulties impairs quality of life in people with dystonia, and some people with dystonia may have also excessive daytime sleepiness, although less commonly reported than impaired nighttime sleep. Some patients who have reduced quality of sleep in cervical or cranial dystonia also have reported and reduced efficacy of alleviating maneuvers like sensory tricks, which is not surprising given that it is possible that increased fatigue coming from poor quality of sleep might lead to a diminished ability to exploit the trick in these patients. Botulinum toxin does not eliminate sleep problems, even when it treats motor symptoms well, which is data that is confirmed by several studies. There's very limited evidence on the role of DBS in sleep in dystonia, and there is one Asian study that has shown limited evidence. That has shown some effect on the sleep quality in people who have MAGE syndrome, so craniocervical dystonia. A very important question that still needs to be properly addressed is how can the use of other medications like benzodiazepines explain these sleep disturbances? Chronic use of benzodiazepines might impair sleep architecture and therefore sleep quality. Fatigue has been explored, but quite little in people with dystonia. And in the couple of studies that have been published recently, more than 40% of patients with dystonia may report moderate to severe fatigue, which also impacts on quality of life and seems to be partially detached from depression or sleep problems. We don't have much knowledge of whether this fatigue improves with treatment. Fatigue, on the other hand, has been interestingly reported as a significant barrier to engagement in exercise and physical activity, sometimes inducing a vicious cycle that aggravates fatigue itself. And this is probably one of the most impactful aspects of having fatigue for people with dystonia. Even in writer's cramp, fatigue may be greater than in control groups, And again, lower scores on fatigue scales may be associated with lower scores on, higher scores on fatigue may be associated with lower scores on the mental component summary of a quality of life instrument like the short form 36. We know that, we suspect, or we essentially know based on our direct experience and on qualitative data that we have collected across Canada, that particularly depression and anxiety are under-screened and under-detected and therefore under-managed in people with dystonia. For this reason, we collaborated with health professionals and patients from 4 different Canadian institutions in Calgary, Edmonton, Vancouver, and Montreal to investigate in a qualitative study barriers and facilitators. This was done by setting up focus groups and interviews to which 45 amongst health professionals and patients participated. We applied state-of-the-art qualitative research methodology to identify relevant barriers and facilitators, and also behavior change techniques that might overcome the identified barriers and promote the implementation of facilitators. And I'm going to now run by you a number of the emerging themes that have come up from this qualitative study. First of all, gaps in knowledge. First theme is that came out from this qualitative research is that patients have knowledge gaps that induce them to believe that depressive or anxiety symptoms may originate from physical symptoms of dystonia, like pain or simply motor symptoms of dystonia. And they also believe, or have been used to believe, that mood and anxiety issues fluctuate over time and fluctuate with motor symptoms or pain, which is not necessarily the case, as some of the latest research has shown. The result of this knowledge gap is that, and of this preconception of mood issues as secondary to other physical symptoms, is that is inevitably that the patients tend to underreport mood problems or anxiety problems. Another important theme is related to the need of educational interventions. So educational interventions using interactive modalities or engaging also health professionals other than neurologists are seen as potentially valid strategies to overcome this educational gap. A third theme that emerged from this qualitative study is related to the fact that emotional symptoms in people with dystonia may aggravate self-isolation and stigma. And these difficulties, although not specific of dystonia, were also believed to prevent patients from declaring their mood and their anxiety issues to health professionals, or even within their social network. On the other hand, there is important data coming from another qualitative research conducted in the UK that has shown that accessing social support within patients' organizations or support groups may have a potential beneficial impact on mood and anxiety issues, and work against the development of self-isolation and stigma. The fourth theme is related to communication skills of physicians. Specialists, in particular movement disorders neurologists, may show limited empathy and limited engagement in discussing and diagnosing depression and anxiety in these patients, often addressing these issues only when they are judged clinically severe. In some instances, family physicians may also show limited engagement, referring the responsibility to address these issues to the specialist. In link with this is this fifth theme of that taps on activities organization at the level of the movement disorders outpatient clinic. Now, these outpatient clinics, the Botox clinics, are perceived as busy, but generally, movement disorders outpatient clinics may not just be Botox clinics, may also serve a mixed population in terms of diagnostic group. Like we may follow in the same clinic people with dystonia who need botulinum toxin, but also patients with Parkinson's disease, tremor, chorea, tic disorders, and others. And so that when it comes to dystonia patients who receive botulinum toxin, we really essentially only focus on botulinum toxin and keep patients for a very short period of time because we see them quarterly. This may lead to temporal and spatial constraints that may hinder adequate screening and documentation of non-motor symptoms in people with dystonia within these clinics. And also, there is insufficient communication between primary care providers like family physicians and specialists with respect to depression or anxiety issues in people with dystonia. I particularly like to read this quote loud because it's one of my favorite. It just highlights the relevance of this insufficient degree of communication between neurologists and family doctors. This is from a patient with cervical dystonia. Around the time of my diagnosis of dystonia, I started feeling anxious around people and often tearful and depressed. My GP told me it was because I had dystonia and to talk to my neurologist. My neurologist disagreed and threw the balls back into the GP's court. I lived like this for more than 3 years, feeling increasingly hopeless, which is particularly disappointing. There is, in relation to an appropriate utilization of local resources, there is an underutilization of specialist resources, especially clinical psychologists or counselors, psychiatrists and social workers at both hospital and primary care level when it comes to optimize management of depression or anxiety and dystonia. Of course, additional barriers were also identified in the potentially elevated cost of screening tools, but also of some specific therapeutic approaches that may not always be reimbursed, like cognitive behavioral interventions. And this slide just summarizes the key barriers that were identified that include, of course, the underdiagnosis of depression and anxiety, the lack of nurses' involvement, lack of coordination of local resources, the limited communication with family doctors, and the limited knowledge from patients and family physicians on these issues in patients with dystonia. Some of the behavioral changes that were broadly identified were the introduction of a periodical screening using self-rated tools in order not to impact on temporal capacity in busy clinical services, the introduction of a care navigation system that is essentially coordinated by the neurologist and or by the nurses, depending on how a certain site and clinic works. The need to timely document screening and treatment to family physicians in notes, and the need to utilize always a multimodal educational package. Now, this is something that needs to be changed through an implementation process. In Calgary, for example, and we know that this is certainly Calgary is not a particularly underperforming site, because we do have particularly relevant attention also to these issues. Symptoms in patients screened positive for depression and anxiety during the research study, we found out that those symptoms had been charted only in 1 out of 5 of these patients, and that clinical screening was essentially random. Only 31% of patients screened positive during the research study had received a management plan, which in the majority of cases came from a family doctor, which suggests that these symptoms are underdetected without rigorous screening, and as a result, they're undertreated. Depression and anxiety rating scales that are typically used and have been developed for the general population seem to perform, some of them may have reasonable accuracy to be utilized as screening tools in people with dystonia. Therefore, this suggests that we don't need to develop a new tool to specifically rate and screen for depression and anxiety in dystonia. There's also a self-rated dystonia non-motor symptoms questionnaire, which taps on all the most relevant non-motor symptoms in this population. And 4 of the 14 yes/no questions that this questionnaire contains are focused on depression and anxiety. There's some data measuring the reliability of this tool as a screening tool for mood disorders in cervical dystonia. This is a study conducted in Dublin on patients with cervical dystonia. And as you can see, they report that a score above 5 or above on this dystonia non-motor symptoms questionnaire is associated with at least with good sensitivity for anxiety and depression. Now, this study has a few caveats. First of all, the fact that the accuracy was measured using the cumulative score of this questionnaire, which, as we have seen, does not only encompass depression or anxiety, but all non-motor symptoms. And the other problem that I found in this study is that the gold standard here were rating tools like the Beck Anxiety and Depression Inventories or the Hospital Anxiety and Depression Scale, which have not really been definitively tested for accuracy against the gold standard, which would be a diagnostic interview. This is a study that we are starting now at an international level with the Dystonia Coalition with the aim to identify the best screening tool for anxiety and depression in people with dystonia. We completed our qualitative study by conducting a Delphi survey with 23 health professionals who are expert in the treatment of dystonia across different professions, and the outcome of this was essentially the development of a bundle of care or pathway of care, which I'm not going to get into great detail. This is just the initial part of it. I just want to give you some key points of this new proposal for a care pathway for depression and anxiety screening and management in people with dystonia. The key points are that we need to screen periodically for these symptoms using self-rated instruments, and at the moment we can utilize the ones that have performed the best in accuracy studies, like the PHQ-9 for depression, or the Beck Anxiety Inventory for anxiety, and that if patients screen negative, screening should be repeated every 6 months. We should document the outcome of screening in clinic notes, and movement disorders clinics, neurologists, and nurses should act as care coordinators or care managers, helping navigating the care for these symptoms for patients. In addition, nurses would have an important role in promoting patients' access to educational tools and to local support groups, and also plan encounters to follow up on treatment actions on depressive and anxiety symptoms that have been decided with the neurologist through phone calls or even in-person follow-up visits. This is just a snapshot of the bottom part of the bundle of care that aims to suggest management approaches that depend on the degree of severity of depressive or anxiety symptoms and of their impact on quality of life, categorizing them as mild, moderate, or high severity, and selecting the most appropriate intervention depending on this severity and impact. One of the aspects of that are part of this bundle of care is to always apply a checklist for ongoing pharmacotherapy to understand if there is any relevant interaction or association between depressive and anxiety symptoms and specific pharmacological classes, drug classes that are used in relatively frequently in people with dystonia. And this is what I'm going to focus on in the last few slides of my presentation. Starting from benzodiazepines. I mentioned earlier that due to their potential beneficial effect on dystonia, and to the fact that patients with dystonia are not adequately followed up for their anxiety and mood problems, there's a tendency for chronic use of benzodiazepines. If this is the case, then neurologists should provide, or nurses should provide education on the risk of chronic intake of benzodiazepines, and depending on the opportunity and the appropriateness of the case, initiate a slow taper. If necessary, we can also use existing guidelines for a safe benzodiazepine taper. There are patients who clearly report receiving transient benefit on motor symptoms from benzodiazepines. So these are the patients in which we could discuss the opportunity of using medications like, for example, clonazepam in short-term courses, always under an appropriate safety monitoring from the neurologist, and making sure that this intake does not become chronic and unmonitored. Anticholinergics are another drug class that is still considered potentially useful in some people with dystonia, even though we need more selective agents from this class to minimize their usually suboptimal tolerability profile, mostly related to cognitive symptoms. But if a patient is on anticholinergics and reports benefit on motor symptoms, then it is important to ask whether whether the start of the anticholinergic treatment or an increase in its dose has in some way been associated with a worsening of depression or anxiety, because there is evidence that of such a potential side effect of anticholinergics. In these cases, obviously, we need to consider dosage adjustment or even replace the medication. Baclofen is is a muscle relaxant that is not infrequently used in people with dystonia, sometimes with some benefit on motor symptoms. And again, we have to pose a similar question as to anticholinergics. If there has been a relationship between a worsening of mood symptoms or anxiety and the initiation or an increase in dose of baclofen, and consider adjustments accordingly. There is some evidence also that baclofen therapy might help mood or anxiety symptoms in the context of substance abuse or post-traumatic stress disorder. So if a patient has a history of alcohol or other substance abuse or of post-traumatic stress disorder, it might be useful to refer this dystonia patient to a psychiatrist to assess whether these comorbidities are contributory to current depressive or anxiety symptoms, and even if baclofen therapy can be considered or optimized in these patients. I mention this in particular because there is also evidence that a proportion of patients with dystonia may have a form of dystonia that responds to alcohol, like it happens in essential tremor. And these patients obviously may be at risk of overusing alcohol. And I'm concluding now with antidepressants because obviously when it comes to pharmacological treatment of mood symptoms, this is the category of reference. It is not uncommon that patients with dystonia who have depressive or anxiety symptoms are already on antidepressants, but the control of mood symptoms with this antidepressant regime is partial or insufficient. In that case, I think neurologists have enough experience to consider changing dosage or even change of agent within the same category, or switching to another antidepressant category, like, for example, from an SSRI to a noradrenaline serotonin reuptake inhibitor like venlafaxine or duloxetine. But it is also appropriate for neurologists who do not feel comfortable in managing this directly to refer to a psychiatrist for this medication adjustment. If the patient is not on antidepressants, but there is an indication to start treatment, And has the patient been treated in the past with antidepressants is the question that we have to ask. And if yes, the first thing is also to make sure that the patient did not observe a clear worsening of dystonia or tremor while on antidepressants. Even though we don't have a lot of safety concerns about using antidepressants with regards to worsening motor symptoms of dystonia, there are a few cases in which this has happened. And so it is useful to ask this question before starting an antidepressant. And if there is this precedent, then it is useful to consider switching agent or antidepressant category. But if there is a precedent or a risk for hypomania or severe mood fluctuations that might suggest cyclothymia or a bipolar even, definitely the recommendation would be to refer to a psychiatrist before initiating a treatment with antidepressants. With this, I would like just to show you my last slide, in which I thank all my colleagues in Calgary and around the world who collaborate with us and help us in the growth of the Dystonia Research Program in Calgary. Thank you very much for your attention.